I'll let you introduce your current role and stuff like that. But welcome everybody to we still have some people joining, but we'll get kicked off because we only have an hour and it's 10:01. Welcome everybody to Fireside Chat. This is a we'll do a little plug here. This is a regular thing that the South Dakota Healthcare Coalition does on the last Tuesday of every month at 10 o'clock in the morning. Next month we have James Robinson. He is from Loveland, Colorado. And for your EMS folks, we've been heavy EMS lately. And James is going to talk next month. If you remember when Scott Phelps and I had a conversation about kind of modifications of MCI models and things like that, James is going to talk a little bit about modification of EMS and things like that for rural EMS. And then the month after that in June, we have to follow up after our conference and the big focus on diversity, equity, and inclusion. We have Tanisa Islam she's right here in Sioux Falls, and she runs Voices for Peace. And that group helps refugees resettle into the Sioux Falls area. And the goal behind what we're trying to do is to not prepare for our vulnerable populations, but to empower our vulnerable populations to be prepared. And so we'll be working with those groups to figure out ways to get more and more and set up some listening sessions for what keeps the regular people up at night, the residents of these communities, of our communities. And we hear a lot of that from our emergency managers and our healthcare folks. But we still need to put a greater focus on vulnerable populations. And so without further ado, I'm going to introduce Brian McGuire. Brian is I'll let Brian introduce himself because most of the people that we have here change and roll through their positions, completely evolving on a regular basis. So Brian has done a good amount of work in researching EMS and paramedic fatalities and so on. And we thought it would be really interesting to hear some of Brian's research and, from an EMS perspective. So Brian, I'm going to hand this over to you. And we'll just keep the chat going as you we'll call it defend your research. and we'll go from there.
Great, thanks. Great. Good morning, everyone. It's a pleasure to talk with you. I am excited about talking to the group from South Dakota. I had a bunch of very enjoyable trips to South Dakota years ago, and always enjoyed working with the people out there. At the time we were working on pandemic and bioterrorism preparedness, but I also managed to fit in some time to see some of the beautiful sites in the state. So today we'll be talking about EMS occupational risk primarily. I'm open to questions and other things, but so there's no conflicts of interest. I'll tell you just quickly about me. At the moment, I am the senior epidemiologist with Leidos, which is a military contracting company, and I am the epidemiologist for a military medical research laboratory in Connecticut. And what I do is much similar to what I was doing. I'm sorry, I'm going to have to interrupt 1 second. Hey, hello. Sorry about that. Had unexpected guests. So my research is looking at occupational safety for the military. I'm also an adjunct professor at Central Queensland University. I lived for 7 years in Australia, where I was a professor there at CQU, and focused there also on occupational safety and EMS education. Our paramedic bachelor's degree program at CQU had about 500 students in the paramedic bachelor's degree. And in addition to the clinical components, one of the things, well, we were experimenting on a few things, but one of them was looking at smart glasses. And I'm continuing that research now with the military, looking at smart glasses and applications, how they can assist medics. I was a 2009 Senior Fulbright Scholar, which is how I went to Australia the first time. I was there for a few months on the doing research, and then one of the deans asked if I would come and work full time. So it was an unexpected outcome, but it worked out really well. I had a wonderful 7 years in Australia. So in total, about 2 decades in academia as university professor, research center director, graduate program director, and about 2 decades in the New York City healthcare system, where I was a New York City paramedic for 20 years, as well as an administrator, an agency president, an operations supervisor, educator, and paramedic. Just a pause for a moment. I don't know if I can see any comments you make in chat. So if you do have any questions, feel free just to give me a shout, and I'm happy to pause and address your questions. And I expect that we'll have time for questions at the end as well. So this is the day my research journey began. I was a hospital administrator at the time, and I had already gone home for the evening. It was a nice summer day, and I got a call that one of my ambulances had an unfortunate incident, and I arrived to find this. That's me standing there with my arms crossed, looking. I'm on the one on the left in jeans. So I, at that moment, said we have to do something about this problem, which I had done some things already about trying to minimize this risk, but I said there's got to be solutions. Somebody must have come up with a solution on how to address this and to prevent these types of things. And I was very surprised to discover in my literature review, looking at everything that had been published, that that there were no publications, there were no solutions for this problem. And so that led me to start developing solutions and looking at risks for EMS personnel. I'm sure most of you are aware of this. I won't spend a lot of time, but just maybe for some people who are not in EMS for a long time, and just so we're all on the same page. So paramedicine clinicians are a huge part of the healthcare system in the United States. We respond to 40 million calls for assistance each year. So it's a huge number of patients and huge responsibility for healthcare. But we also operate at the intersection of a variety of really critically important public functions. So we are a big part of public health. We're a big part of public safety. We're a huge part of disaster operations as well as of healthcare. And paramedicine clinicians include emergency medical technicians and paramedics. Within the EMS system, there's also a whole bunch of subsections that we don't always think about, and people outside the profession aren't always aware of. So we provide a huge component of mobile healthcare, taking people not only to hospitals, but taking them from hospitals to healthcare sites such as dialysis. We do more and more community care, and this is, to me, a very exciting component of how EMS is evolving. In this regard, Australia has really taken the reins and has leaped into this with community care paramedics. And in Australia, they have a master's degree that prepares paramedics to be community care paramedics. And they recognize the value of community care paramedics. I'll tell you just a quick anecdote. One person was going for a job interview, and the job interview went well, and the interviewer at the agency was saying, so do you have any last questions? And the paramedic said, well, I got to tell you, I'm not taking this job unless you pay me $125,000 a year. So the interviewer says, well, that's a problem because all our other community care paramedics are paid $150,000 a year. So they are well recognized, well compensated, and are doing some amazing work in community care. Injury prevention is something that we do more and more of, and we can do more and more of. I'll tell you about a real turning point in EMS history in a little while, but there's a lot more that we can do about injury prevention. And as recent events have demonstrated, we do a lot in the way of disaster operations and are a critical component of disaster operations, as we saw in COVID and various hurricanes, 911, mass shootings, et cetera. And oh yeah, by the way, we also do EMS 911 calls. So that's our system is not always well recognized by the public, but we have tremendous responsibilities and play a critical role in healthcare and other public service components in the United States. So I'm going to focus now for a little while on occupational risks. What started this off was a new fatality research, but we'll also talk a little bit about injuries and violence and reducing risks. And again, any questions if you have any questions as we go along, feel free to give me a shout. So this is hot off the presses, was just published last month, and it's looking specifically at occupational fatalities from 2003 through 2020, published in Pre-Hospital and Disaster Medicine. So here we see the fatalities per year, and that's the first thing we see there is that's way too many dead paramedics. There's way too many occupational fatalities in our profession. The next thing we see there is that a huge component of our risk is transportation incidents. And so there's a lot of people dying every year from transportation incidents. So it's a big problem for our profession. And we're all on the same page. Transportation incidents includes people dying in ambulance crashes, paramedics and clinicians working on the side of the road on the highway, get hit by a car and getting killed. And when we work in helicopters or other aviation and crashes related to that. So there's all of those things contribute to transportation incidents. So maybe we'll pause for a moment. I don't know if I can see text, but why don't you take a moment and think about how you think the other component, how else are paramedicine clinicians dying? So let's just take a moment, think about what other causes do you think there are for people in our profession to get killed? And while you're doing that, I'll go to the next slide, but feel free to jump in. And what other ways do you think people are dying in the profession. When we look at risks by sex, one of the things that's that is a surprise to many is that there is a big difference for fatality rates between men and women. And so we can see there's that men in the profession have a much higher risk of fatality than women. And so this is the rate for every 100,000 men compared to the rate for every 100,000 women in the profession. I don't know if the chat is working. I'm not seeing any chat entries.
Yeah, I don't see any questions in the chat either.
Okay, well, if you get a chance, jump in, anybody, you're welcome to put in that. So when we were going through COVID, so this is in 2000, one of the risks to paramedicine clinicians in terms of fatalities is in the last couple of years has been COVID. So we see here that the rate of COVID fatalities among EMS personnel is higher than fire, higher than police, much higher than nurses and physicians. So EMS personnel really took the brunt, or took a huge hit for COVID fatalities. Greg, for whatever reason, I'm not seeing the chat. So is there, I see that there's a few that are there, but I don't see a way to read them.
Yeah, there's speculation on fatality types, heart attacks, suicide. So there, and and there's an agreement on suicide is a big factor in fatalities. When you look at numbers like this.
Great. Okay. Thank you. Good points. So transportation related, this was a previous fatality study that I did. And here we looked at, compared the transportation related occupational fatality rates. And we can see that the rate for EMS is about 5 times higher than the national average for all workers, and a good bit higher than for police and fire. So our risks of transportation fatality are considerable. And yes, suicide is unfortunately a big part of the problem. And unfortunately, we have very little data to be able to quantify this problem. So we think that the rate could be many, many times higher than the national average, but we don't have enough data to actually be able to quantify that. And this screen could be filled with many, many pictures, but these were 2 of my former coworkers in New York City, and they've been gone a long time, and we still miss them. So if you have any questions about fatalities, feel free to put them into the chat, and Greg, you can feel free to jump in and let me know. And we'll move on to injuries. So this is, I'll first tell you a little bit about a project that I have recently submitted for publication. So it's not yet published. I'll give you a little bit of a preview and then talk about some other research that is already done. So this one that I just submitted for publication is looking at the Department of Labor, Bureau of Labor Statistics data, and looking at non-fatal injuries among, excuse me, EMTs and paramedics for 2011 to 2020. So here we see the rate of injuries. These are non-fatal injuries per 10,000 EMTs and paramedics per year. And so we can see that it jumps around a bit. The column, the total column, we can see it moves around a bit, but what looks like a huge jump in 2020. So it's going to be important for us to be able to look at, see how this continues. Is this a precursor of a trend? So is 2021, 2022, 2023, again, much higher. We don't know those numbers yet, but this is a concerning trend. And we also, not surprisingly, saw a decrease in transportation-related injuries, but shockingly, we saw a huge increase in violence-related injuries. So this is a big problem for our profession. I could talk to you a whole lot about violence. I'll do just a couple of slides on it, but feel free if you have any questions about violence or of any of this, put it in the chat box or give me a shout, and I'm happy to spend some more time talking about it.
Yeah, Brian, I actually have a question on that. When it comes to violent incidents, is there a jump? Are you finding in your research a jump in violence based on like cluster events versus individual violent attacks? On scenes of like law enforcement has domestic. They have a lot of injuries secondary to domestic disputes, etc. Or is this something where we've seen a surge of protesting and things like that would result in injuries to first responders overall?
Yeah, those are great questions, Greg. And unfortunately, nobody, as far as I know, has any of those answers. And it's a real problem for us because, as you point out, there could be very different causes for some of these violence-related injuries. And without us having the answers to those questions, it makes it very difficult for us to come up with interventions to reduce the risks for our personnel. So those are questions that we desperately need to answer. But at the moment, nobody has those answers.
Yeah, and and it looks like from transportation and violence, they talked about the change in mental health issues because of lockdowns and stuff, but I don't know that 2020 data, because that all started kind of mid-2020. It'd be really interesting to see the trending into 2021 and 2022 based on COVID lockdowns and stuff, whether or not things are continuing to trend upward or not.
Absolutely. And we know that EMS workforce was really impacted dramatically by COVID, and it's going to be important to be able to document specifically how that impacted the workforce. So overall injuries. So here, so over 7,000 injuries a year. Now, to put this in perspective, this is not minor cuts and bruises. These are all injuries. In order to get in this list, the injury had to result in medical care, result in time lost from work. So we're not talking about minor stuff that happens to lots of our personnel very often. These are all pretty serious cases for them to wind up here. So over 7,000 a year for our personnel. So that's a lot of injuries. Most of the injuries were musculoskeletal. So that's a big part of the risk for us. But one of the things that we found when we looked at differences by sex is that now we're seeing for non-fatal injuries that women actually have a higher risk than men. So it's about 30% higher for men for women compared to men. So that raises an important point and an important question for us. Why is that different? And the fact that it's different means that there could be, well, first of all, it means that these are not random events. So we saw both in the fatalities and the injuries, when we see differences in rates by different groups, one of the first things that tells us is these are not random events. If they were random events, we'd see the same rates across the board, but we're not seeing the same rates across the board. So that means they're not random. And if they're not random, then they can be predictable. And if they're predictable, they can be preventable. So it gives us some insights into these are not situations that there's nothing we can do about them. The fact that they are not random means that there are things that we can do to mitigate these risks. The other thing that it means is because there are differences between men and women, it means our interventions will likely have to be different, at least to some extent, for men and women. So I'm a pilot, and one of the things that we know from aviation research is that male and female pilots crash for different reasons. So we're seeing some of the same things here in EMS that we're getting, if the injury rate is different, it might mean that they're getting injured for different reasons. And again, it reinforces the importance of sex-specific research and sex-specific interventions. Four of the main findings from this current research. Again, it reinforces that EMS is a high-risk occupation, that women have higher rates of injuries compared to men. The risks of violence and transportation are both very high. So both are 5 times higher than the national average. And we saw also about the rate of violence rising pretty dramatically. And the fact that the high rates compared to other groups. So one of the other things we looked at is comparisons to other groups, and that the rates for EMS is much higher than the rates for other occupational groups, shows that this is a critical topic that needs attention and needs interventions. I'll spend a few moments talking about violence. Again, this is something I have a whole lot of research on violence. Happy to talk if you have specific questions about any of that, but I'll just do a couple of highlights right now. So this is violence-related injuries, non-fatal injuries, EMS compared to the national average. So about 30 times higher. The risk for EMS was about 30 times higher than the national average. So this is a huge problem for our profession. This is a paper that was published in the American Journal of Public Health that I looked at occupational injuries from 2012 to 2015, and looked at one of the things looked at was perpetrators. So 77% of the perpetrators were patients. Not surprising, somewhat surprising. 8% of the perpetrators were coworkers. So that shows an important finding. We found that female personnel had a disproportionately greater risk of violence-related injury. So again, looking at sex differences specifically for violence, that women are in our profession are at higher risk of violence-related injuries compared to men. Why is that? We don't know. We absolutely should know. It's horrible that we don't know, and we need to know, so that not only can we document it, but that we can prevent it and make this job safer for women in the profession. So what we see here, over 400 serious assault-related injuries a year in the United States. Way, way too many. What we also know from other research is that there is on average at least, there is on average a homicide a year, fatal injury among paramedicine clinicians, on average, one every year. A horrible, horrible, way too common, way unacceptable occurrence. So what can we do to reduce these risks? Well, before I start that, any questions about anything we've covered so far? Questions about fatalities, non-fatal injuries? Any questions so far?
I don't see anything in the chat box. I would be interested for the EMS folks on the call to throw in the chat box maybe any experiences they may have had, personal experience they may have had with violent patients or violent patient families, just to get an idea of how common it actually is even here in South Dakota.
Yes, that would be very good. Excellent. Okay. So we'll move on. Again, feel free to shout or put in something in the chat box anytime. So let's talk about reducing risks. So after many years as a paramedic, I did a doctoral degree in public health. And one of the discoveries for me was that there are a lot of similarities between what we do as paramedics and what we do in public health. And so how we treat a patient, we have slightly different types of patients in the two realms, but a lot of the same approach. So as paramedics, we do an assessment, vital signs and history. In public health, our assessment is look at statistics, calculate rates, do a literature review to find out what's happening, what other people's experiences have been. Then the next thing we do as paramedics and EMTs is to choose or develop a treatment. So now we've done an assessment of our patient. Now we want to treat the patient or figure out what we're going to do to treat the patient. And the same thing we do in public health. So we have, just like paramedics, we have a kind of a tool belt of different types of ways of evaluating interventions and doing interventions. And so we can see what the problem was and then develop an intervention. And then the next step for both is very similar. Again, as paramedics, we treat the patient, and then in public health, we implement our intervention. And here, critically important for both is once we do the treatment, we give the medicine, we do whatever it is that how we're going to treat the patient, we do a re-examination of the patient to make sure, well, A, that the patient didn't get any worse from our treatment, and B, is what we're hoping is going to be the outcome, is that the patient has, in fact, improved. So that's a critical part of the process for both EMS and for public health. So I talked about the tool belt that we have in public health. We have lots of things in the tool belt. One of the things that I find is particularly relevant is the 4 E's of injury prevention. So it's education, engineering, enactment of policy and legislation, and enforcement of policy and legislation. So let's see an example of how that has worked. So in Pinellas County, Florida, years ago, a bunch of EMS people were at a conference, and one was talking to another and saying, I've been going to a lot of pediatric drownings lately. And the other person said, I've been having a lot of pediatric drownings lately. Wonder what's going on. So they got the data, they examined the data, and they found that the number of pediatric drownings in their county was actually rising pretty significantly. So they said, we have to do something about this. And so they got together, they brought a group together of paramedics, physicians, nurses, county lawmakers, county representatives, and got everybody in the same room, epidemiologists, got everybody in the same room. And why I think this was a particularly significant turning point in EMS history is up until this point, when groups like that got together, the outcomes were mostly, how can we get there faster? What new drugs can we use? What new tools can we use? But that group asked the question, what can we do to prevent this? And that led to an incredible outcome. So the first thing they did was, well, let's figure out how kids are drowning. So I'll give you a moment to think about, how do you think kids drown? So they examined all the records, and they found, really surprisingly, that the number one most common way that kids were drowning in their county was in the bathtub at home. So the typical example was that the parents started the bath, and in those days there was no cell phones, and the phone rang in the other room, and the parent figured, I'll be back in a minute, and came back 5 minutes later, and found an unimaginable finding. That was the most common way that kids were drowning. Of course, kids were also drowning in swimming pools, but another very common way that was a surprise to many was that many kids drowned, again, with their parents just a few feet away from them, while the parent was washing the car. And there was a bucket on the other side of the car, and the toddler playing with the bucket fell headfirst into the bucket, didn't have the upper body strength to get out of the bucket, and 6 feet away from a completely unsuspecting parent, the kid drowned. Again, an unimaginable outcome. So then they figured out, well, what do we need to do about this? How are we going to solve the problem? And they realized that one of the most important, powerful solutions is education. People don't need a master's degree in this. If you tell a parent one time that kids drowned in bathtubs when the parents are 6 feet away, or they drown in buckets when the parents are 6 feet away, a parent will never, ever conceive of the possibility of letting a kid be alone in that situation ever again. You've completely changed their behavior for life. So that was a big part of it. Educate the community. This is what's happening. This is how kids are drowning. And of course, kids were drowning in swimming pools too. And so that brought up other solutions. So the engineering solution to that is you put fences around swimming pools. And then the enactment of legislation solution is that you make rules in the community that if you have a swimming pool, you have to have a fence around it. And then the fourth E is enforce that, and that you enforce that rule that if you have a swimming pool, you have to have a fence around it. So that's what they did. They used the 4 E's, and they cut the pediatric drowning rate in their county by 50%. How's that for a powerful EMS intervention? Tremendously powerful EMS intervention. And for us as EMS professionals, do we want to be the ones who got to the pediatric drowning faster, or the ones that prevented the pediatric drowning from happening in the first place? There's a lot that we can do to prevent injuries. And we saw that in Pinellas County with pediatric drownings. And we can use those same lessons when we're talking about how to save our coworkers and ourselves. So what are some agency level approaches? The first thing is that unlike EMS, we have to take a different approach. So as EMTs and paramedics, we are very, very confident and capable of working completely by ourselves. There's been lots of times I was driving along in my car, came upon a horrific crash, jumped out, and was very comfortable in taking care of everybody all by myself. So we have to have that confidence and capability to act independently. But this problem does not get solved by one person. The only way to solve this problem is through a team approach. And that team has to include EMS personnel, leaders, union people, epidemiologists, engineers, physicians, nurses, and government officials. The only way to solve this problem is through a team approach. And of course, we need funding to do that. So this is a busy slide, but it's important for us to be able to put it all in one place to see all the different components in this solution. And while it looks like a whole lot, if we put what paramedics do, what EMTs do for the general population, we'd have a very complicated slide too. But for us as EMS professionals, that slide would be very easy to understand. So as we develop our expertise in public health, this will become easier and easier to understand. But I'll walk through it now to for us to get a kind of an overview of how this all kind of works. So first is we identify a problem, and then we put together a team to try to solve that problem. The data system is a critical component of any solution. So just like we need to take vital signs in order to know what to do for the patient, we need data to know what to do to solve occupational hazard problems. So we need personnel files, we need medical records, we need operational records, we need incident investigations. And by the way, in order to have data on incident investigations, we need to be doing incident investigations. It's a critical job that's unfortunately not always done fully in many EMS systems. So all of these are some of the data that are critically important to have in our data system. And then we need to look at, well, what are identifying contributing factors? So does sex contribute? Does age of the, we know from other research that 50-year-old EMS professionals and 20-year-old EMS professionals have different occupational risks. So of course, age is a component. And that again indicates that we need to, any intervention we do needs to have some age component. Greg brought up great questions about what do we know about things like calls and how types of calls or types of incidents affect our risks. At the moment, we have very little information on that, and we need to know more and more. We need to know, well, how does time of day affect our risk? How does type of call affect our risk? And again, Greg made a great point about, cops a long time ago figured out that domestic disputes are a huge risk for cops. That's where a lot of cops get assaulted. And so they took extra, they have policies and procedures to help protect cops in that situation. And many departments, anytime that type of call comes in, it's not a single or dual cop response, it's a multi-police officer response. So those are the types of things that we need to be able to do for ourselves, that maybe there are some types of calls that we shouldn't be going in on, but maybe we don't know all of them at the moment, and that we won't know them, what those are. We won't realize what those are until we start doing some analysis to see how does the call type relate to our risks. And of course, we could go lots and lots about dispatch and call center data collection. But this is just a kind of a 30,000 view overview, 30,000 foot overview. So then we get all that, and then we develop and test interventions. So these next two parts, we sometimes have to go back and forth in that we figure out what we think will work in terms of an intervention. We try it out. Maybe it doesn't work as well as we thought. Maybe we need to tweak it. Maybe we need to change some things. And we find that when we evaluate the outcomes. So we go back and we retest, we redevelop, we retest, and we keep that loop going until we have something that we're happy with. And then we implement the interventions. So what are the 4 E's for us? And we're not going to have a lot of time to talk about that, but I invite you to think about how the 4 E's might be used to help reduce risks for EMS personnel. So I'll start a couple. So education is a critically important one. And we need to be able to educate people about their risks. One of my studies was a survey of over 600 EMS personnel who had been victims of violence, and what they can tell us after the fact that might help prevent it in the future. And one of the recurring comments from many of them was that it didn't occur to me that somebody would assault me. I was completely unaware that I was at risk of being assaulted. And that was a common response. And so I think we need to do much more about educating our personnel about situational awareness, and that they could be victims of assault. So that is a big part of education. And there's lots of other parts, other things that we could be educating people about, related to violence, for example, how to diffuse violence, how to protect themselves. I became a black belt in Taekwondo around the same time as I became a paramedic. And I don't think that, and I don't propose that all EMS personnel become black belts, but I do think that it's very important that we have some ability to protect ourselves. And I think it's a joint responsibility between the EMS professional and the EMS agency to say, how can we work together to prepare people for these types of events? And I think from an agency perspective, it means providing training. From a personnel perspective, it means recognizing that a 1 hour class or even a couple of hour class is not necessarily going to be sufficient for you. So I urge you to think about education. For those of you who are administrators, what can we do as administrators to best offer? What types of training can we offer and make available to our personnel? And from a personnel perspective, what do we have to do to take personal responsibility for our safety? So education, engineering, we saw some engineering interventions during COVID. So it's things like masks. So unfortunately, we also know that PPE, personal protective equipment, is way down the list in terms of effective interventions. But it's one of the tools, and we need to be able to use that as a tool to prevent and reduce our risks. So, and then enactment of policies. So, one of the things that in other professions has found that agencies that are very proactive in terms of safety, including having policies that relate to occupational safety, that those agencies have have lower occupational injury rates. So it is important for leadership to be developing and to have safety policies and procedures, to share them with their personnel. And the fourth E, to enact and enforce those safety policies. That we're not saying wear your seatbelt all the time just to have something to tell you to do. Seatbelts are critically important for our personnel. So that's just a quick overview of how some of the 4 E's might be used. I'm happy to chat more about that. And then published findings. So one of the things that unfortunately we have not been great at so far as a profession is sharing our findings. So there's over 20,000 EMS agencies in the United States, and probably every agency has done something to try to reduce some aspect of occupational risks for their personnel. But we have almost nothing that's published about that. And so that for us as a profession, that means again and again and again, we're reinventing the wheel and doing something that has been done 20 times before, and we don't know about what happened those 20 times. And so we're going down the same dead end again and again and again. So we need to share our findings, even those findings where what we did was not successful. Everybody says, how can we afford this? And it's a reasonable and important question for our profession. And we're struggling as a profession in the United States. And again, this is very different from other countries. In other countries, EMS agencies are well funded and are not struggling with these things and do not have to duct tape their ambulances or have bake sales to cover costs. But here in the United States, at the moment, we're having a real tough time paying for EMS. So it's not an easy, there's no easy answer. But some of the things I think that we as leaders have to think about or consider is that generally, for safety research, every dollar invested in safety has a $3 return on investment. We have to think about that paying for safety may be much less costly than not paying for safety. That upside down ambulance is a very expensive, unfortunate, avoidable outcome. And there may be grants available to help us develop these interventions. And instead of, another possibility, instead of every agency trying to do this on its own, there might be cost-effective ways to have groups of agencies all working together to help shoulder the cost and to help develop these interventions and implement them. So that's from an agency perspective. But there's also things that we can do on a personal level. And so we know seatbelts work. Wear seatbelts. I know, again, from personal experience, there are times that we need to take care of a patient, but I think there's things that we can do. So maybe we have a rule that if you're in the back of the ambulance with the patient and you have to take off your seatbelt, you tell the driver, I'm taking off my seatbelt, and the driver slows down to 20 miles an hour. Now, that's not going to prevent you from getting killed, but it reduces your chances of getting killed if instead the vehicle was traveling at 50 or 60 miles an hour. So have a rule with your partner that if you have to take off your seatbelt, the ambulance automatically slows down to a safer speed. Smoking. We all know about smoking. People who smoke have higher crash rates than people who don't smoke. We don't want people to be smoking or using drugs or alcohol. Strain. We know that a huge part of our risks are lifting related, practice safe lifting and carrying. Speed. Drive safely all the time, and just what we talked about, slow down when the crew is unbelted. Survey. Be aware of risks in the environment. So we talked about the EMS personnel who couldn't conceive of the possibility of getting assaulted, but it does happen. So be aware of risks and have a plan. So again, as a pilot, before every flight, every time before every flight, we stop just before we pull out on the runway, and we out loud say, if my engine fails here, this is what I'm going to do. If my engine fails here, this is what I'm going to do. We say that every time. So what I suggest, the lesson learned for EMS is, at the beginning of every shift, we have a plan with our partner. If at any time you feel at risk, you say to your partner, can you give me a hand with the green bag? And give me a hand with the green bag means we drop everything. We don't care about the equipment we leave behind. We're going to get out. We're just going to leave. So have a plan. Stress. We know that stress is killing us. Keep stress at a healthy level. We know we need sleep. Lots of paramedics and clinicians are dying because of fatigue. We have to be healthy. We have to exercise regularly. Self-defense, practice regularly. Support and encourage research and education. We need more research and education. I was one of 6 paramedics on the planet who were university professors. We need more paramedics to be university professors, because they provide a critical resource for a profession. Nurses and physicians have hundreds of professors who are helping those professions evolve and develop. We need to encourage research and education, and we need to support each other. So conclusions, reducing these risks. We need funding, we need better data systems, reevaluation of training, improved PPT, personal protective technology, interventions on improving physical fitness, new administrative supports, new training, including situational awareness and safety preparedness. Risk reduction will save lives, will reduce turnover, and will help us as a profession provide the best possible care for the 40 million people who rely on us and call for our help every year. Risk reduction does work. Fortunately, the 2 guys in this ambulance were okay, but that upside down ambulance led to research that reduced the ambulance crash rate by 50%. The research does work, it can be done, and we can make the job safer. Thank you. Any questions?
Does anyone have any questions? You can unmute yourselves. I don't have the ability to unmute. If you have questions, you can unmute, or you can type a question into the chat box. You get a quiet group this morning, Brian.
Yes, yes.
All right. Well, I want to thank you very much. I want to thank everybody for coming, and I want to thank Brian for sharing his research and his wisdom. We will. We're getting a couple of thank yous and very interesting in the chat box side of things. And we will just to let everybody know, we tried to get Brian to come to the conference, but he is out of the country, I believe, at the time. So we will be uploading this to the Dropbox, and you guys can download it and watch it, share it at your EMS agencies and so on. So Brian, thank you very much for your time. We definitely appreciate it, and I'll be reaching out. We'll talk again soon, I'm sure.